my dear students. Welcome back to this life-saving education on all things having to do with your gynecologic health in general and your menopausal health in particular. I'm Menopause Taylor, the gynecologist who is determined to give you the education you deserve. If you're new to this channel and this is your first video, you should know that you've started in the wrong place. Unlike most things on YouTube, this channel is really a classroom where I give you a real education. And like all real educations, you have to learn everything in order if you want any chance at all at success. So if you've already watched all the videos preceding this one in order, you're ripe and ready for this one. And if you haven't, you're shooting yourself in the foot or in the head. This is video number 458, and it addresses management and treatment of polycystic ovary syndrome, also known as PCOS. It's the fourth video in this PCOS unit. Video number 455 introduced you to PCOS as a 3-organ system disease. Video number 456 presented the 3 hormonal abnormalities of PCOS. Video number 457 addressed diagnosis of PCOS. So now it's time for you to learn about the management and treatment options available for PCOS. Now, if you're wondering why you need to watch this video, it's because PCOS is very common, but commonly disregarded or never diagnosed. And I do not address PCOS in my book at all, in either the first or the second edition. You can always count on a more in-depth education from these videos than from any other of my other educational resources. And the only way to get it all tailored specifically to you is in a consultation. All right. So what if you receive a diagnosis of PCOS? What do you do about it? Well, obviously this depends on your age and reproductive status at the time of diagnosis. The biggest predictor of successful management and treatment of PCOS is early diagnosis and treatment. Unfortunately, that is all too rare. In the last video tutorial, you discovered that there are many different indicators of PCOS. The problem is that instead of paying attention to all of them, the prevailing diagnostic criteria focus on just 3 things: high testosterone, irregular infrequent periods, and multiple ovarian cysts on pelvic ultrasound. And the bigger problem is that if you focus on only these 3 things, you are likely to miss the diagnosis altogether. And that's detrimental for your future regardless of your age. My goal with this education is to empower you to take control of your health. Just because the healthcare system fails in diagnosing most cases of PCOS does not mean you have to forfeit the opportunity to treat it if you suspect you have it. So this video will present all your management and treatment options for PCOS. And one of the most important things I'll do in this video tutorial is distinguish management options that can treat the underlying PCOS from management options that cannot treat the underlying PCOS. You know, when I teach you about medication options, I greatly simplify things for you. Medications involve all sorts of scientific subjects that most people hate, like pharmacology, therapeutics, molecular biology, and biochemistry. Well, I'm a nerd, so I love all those things. But if I bothered you with all the details that form the basis of those subjects, you'd run away screaming. So I just limit my lessons to the information you need in order to accomplish your goals. And I always like to make things easy for you to understand things. Quite often, the best way to do that is with a chart. So let's create a chart to delineate management and treatment options for PCOS. Here's the skeleton of the chart we'll create. What you see here is that the first column has our 3 organ system abnormalities for PCOS: dermatologic, reproductive, and metabolic. The second column shows the abnormal hormone for each. The third column shows the source of the abnormal hormone for each. The fourth column is the symptoms caused by each abnormal hormone. And the fifth column shows the official diagnostic criteria for each. The sixth column designates the management options that can actually treat PCOS. It's still blank because we'll be filling it in as we go along. And the seventh column designates the management options that cannot actually treat PCOS. And it's also blank because we'll be filling it in as we go along. To review, you've learned that PCOS is not a disease of just your ovaries. It involves 3 separate organ systems: dermatologic, reproductive, and metabolic. It also involves 3 separate hormonal abnormalities from 3 separate organs: high testosterone from your ovaries, high luteinizing hormone from your brain, and high insulin from your fat. Fortunately, unlike the diagnosis of PCOS, which focuses on only one of the organ system abnormalities, proper management and treatment of PCOS targets all of them. So, in keeping with our organized scheme, I'll go through each one and delineate all your management and treatment options. And I'll also distinguish which ones can actually treat PCOS and which ones cannot. The first organ system abnormality is dermatologic. It manifests as cystic acne, hirsutism, which is male pattern hair growth on your face, chest, abdomen, and arms, and male pattern hair loss on your head. All these dermatologic manifestations of PCOS are due to excessively high testosterone levels. So the focus of management and treatment for them is on lowering your testosterone levels. But, what is the source of the high testosterone? Your ovaries. And it is critical to focus on treating the source of the hormone abnormality. So here's what you need to know about management and treatment options for these symptoms that are due to high testosterone. And before I tell you about the actual options, let's talk just a bit about the name for these options. The medication options that can treat them are called anti-androgens. Androgens are all molecules that function as the male sex hormone. Long ago, I taught you that the 3 sex hormones are like the 3 bears in Goldilocks and the 3 bears. Testosterone is Papa Bear's hormone. Estrogen is Mama Bear's hormone. And progesterone is Baby Bear's hormone. The idea is to associate each hormone with its role for each bear. Well, there are various different kinds of testosterone. And there are hormone molecules that actually transform into testosterone. But they are all considered androgens. So when it comes to treating something that is due to high testosterone, the medication options for doing so are called anti-androgens. Anti-androgens are testosterone blockers. So the idea behind using an anti-androgen to treat symptoms that are due to high testosterone is to block the ability of the testosterone to exert its effects. The most common anti-androgen for treating symptoms that are due to high testosterone is spironolactone. You may have heard of it. It's the one that has been available for the longest period of time, but it's not the only one. 2 others are finasteride and flutamide. The symptoms of high testosterone are very bothersome. If you're a young woman with cystic acne, hirsutism, and male pattern hair loss, you suffer with more than just those symptoms. It's emotionally scarring for a young woman to have cystic acne, excess hair in masculine locations, and male pattern hair loss that amounts to balding. The longer a young woman endures these symptoms, the more emotional damage she suffers. So the goal of treatment for the symptoms of high testosterone is to treat it early. There's an expression that is apropos here. The early bird gets the worm. It means that the person who arrives earliest is the most successful. Well, for purposes of treating PCOS, we can modify that quote to the early bird gets the norm. Norm is for normal. I've modified my t-shirt to say the early bird gets the norm instead of the worm. And the key is to understand that the earlier you treat these symptoms of testosterone excess, the more successful you will be at treating all the consequences of PCOS, including the emotional damage it can cause. The big mistake would be to treat these individual symptoms, but ignore the fact that your ovaries in general, and PCOS in particular, is the root cause. This is why it is so important to distinguish the management options that can treat PCOS from those that cannot. Treating cystic acne superficially, but ignoring the fact that it's due to high testosterone, would really miss the underlying problem. And removing unwanted hair on your face, chest, abdomen, and arms, but ignoring the fact that it's due to high testosterone, would really miss the underlying problem. Likewise, stimulating growth of wanted hair on your head, but ignoring the fact that male pattern hair loss is due to high testosterone, would really miss the underlying problem. So if you have any of these symptoms, just be sure you have an assessment for PCOS before deciding how to manage them. Okay, here we go. The first symptom of high testosterone is cystic acne. There are all sorts of acne medications. There are antibiotics for acne. There's retin-A medications for acne. There are even skin drying products for acne. But treating just the acne while ignoring the fact that it's due to high testosterone would completely miss the underlying problem. Anti-androgens are the only treatment option that can treat both the acne and the underlying PCOS as its cause. The second symptom of high testosterone is hirsutism. You can treat hirsutism itself with F-ornithine cream by the brand name Vanica. It's a very slow way to transform coarse black hairs into fine blonde hairs. But unlike the anti-androgens, which treat the actual PCOS, Vanica is topical, and it merely treats the symptom of hirsutism without treating the actual PCOS. It will not treat hirsutism as well as the anti-androgens do, and it will take a very, very long time to see any difference, months to years. Another option for hirsutism is hair removal. This is possible using electrolysis or laser. Both can remove hair permanently, but they do not treat the real problem if you have PCOS. Of course, you can shave or tweeze your unwanted hair, but it's going to grow back. So once again, anti-androgens are the only treatment option that can treat both the hirsutism and the underlying PCOS as its cause. The third symptom of high testosterone is male pattern hair loss. In addition to anti-androgens, there are all sorts of management options for this too. You can use a hair growth formulation like Rogaine, You can take hair growth vitamins and minerals. You can use an infrared light device to grow your hair. You can get a hair transplant. And you might want to do these things in addition to taking an anti-androgen. But if you omit the anti-androgen and utilize only one of these other options, you will be ignoring the real problem. None of these can treat the actual PCOS. Anti-androgens are the only treatment option that can treat both the male pattern hair loss and the underlying PCOS as its cause. So while there are all sorts of options for managing acne, hirsutism, and male pattern hair loss, the only management option that focuses on your ovaries as the actual source of the increased testosterone and actually treats the PCOS is an anti-androgen. And treating it early is key. The early bird gets the norm. So let's put this on our chart. Now you see that I've inserted anti-androgens into the 6th column for management options that can actually treat the high ovarian testosterone dermatologic symptoms of PCOS. They include only the anti-androgens spironolactone, finasteride, and flutamide. In the 7th column, I've designated all the other management options that cannot treat PCOS. All they do is treat the obvious symptoms. Our next organ system abnormality is reproductive. The actual official diagnostic criteria include only 2 things: irregular infrequent periods and multiple ovarian cysts from this category. But these 2 things are not representative of the true underlying pathology of PCOS. So I'm going to break this reproductive organ system into 2 parts. That way you'll understand what's really necessary for treatment. I'll divide the reproductive abnormalities into no ovulation and ovulation. I'll start with no ovulation, better known as failure to ovulate. Back in video number 456, I taught you that PCOS entails menstrual cycles with no ovulation of an egg. With PCOS, instead of maturing just one single egg, the high luteinizing hormone, or LH, from your brain makes a lot of eggs start the process of maturation, but none of them makes it to full maturity. So you end up with irregular, infrequent periods and a bunch of ovarian cysts that are failed attempts at ovulation. Failure to ovulate results in failure to shed your endometrial lining, so it just stays thick for long periods of time. And when it finally sheds after many months of buildup, your periods are heavy. At perimenopause, even though your periods may become more frequent, they are still heavy. We call these heavy periods abnormal uterine bleeding. And even though you may shed a lot of the thick endometrial lining with your heavy bleeding, the very fact that your endometrial lining tends to be thick increases your risk for endometrial uterine cancer. So all of this failure to ovulate over the course of your reproductive life adds up to a high risk of endometrial uterine cancer. As you can see, failure of ovulation accounts for most of the common reproductive features of PCOS. These include irregular, unpredictable, infrequent, or absent periods, infertility due to failed ovulation, abnormal uterine bleeding at perimenopause, and increased risk of endometrial uterine cancer. And the best, most effective, truly transforming management option that can treat all these symptoms as well as the underlying PCOS is, dun 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 dun, birth control pills that contain both estrogen and progestin. Now, the reason estrogen plus progestin containing birth control is so effective is that it inhibits the entire process of ovulation altogether. So, instead of harvesting a crop of immature eggs and failing to ovulate any of them, your ovaries do not embark on the attempt at ovulation at all. Now, let me give you a word or two of caution. If you have PCOS, you do not want any birth control option that consists of progestin only without estrogen. Nor do you want any kind of progestogen that is not a form of birth control. Nothing that contains progestogen only will have any effect on treating the actual underlying PCOS. Remember, the very cause of failure to ovulate is high luteinizing hormone, LH, production in your brain. Well, LH controls progesterone production. And if LH is high, your progesterone is low. But you cannot fix the ovulatory problems of PCOS with progestogen alone. Another way to say this is that you cannot use baby bear's hormone to fix mama bear's problem. You need both estrogen and progestogen. And because the whole purpose of treatment is to avoid ovulation and prevent thickening of your endometrium, there is a particular kind of estrogen plus progestogen birth control pills that are best for treating PCOS. You have to realize that PCOS messes up your hormone cycles altogether. So the very best way to treat PCOS is to erase your hormone cycles altogether. And there are two critical characteristics of the right birth control pills for doing this. First, you have to take monophasic pills. Second, you have to take them in a continuous regimen, and I'll address each of these in turn. The first is that you want your birth control pills to be monophasic. Monophasic means one phase. One phase simply means that all the active pills contain the very same dosage combination of estrogen and progestin in every pill. Monophasic birth control pills look like this. Notice that all of the active pills are the same color, white. These brown pills down here are all placebo with no hormones in them at all. A monophasic birth control pill will create hormones that are always consistent with no variation from day to day, and that will prevent ovulation. The other big benefit of monophasic pills is that they prevent your endometrial uterine lining from ever thickening. Estrogen alone functions as fertilizer to make the inner uterine lining thick. Progestogen alone functions as a lawnmower to shed the thick lining. By having the same dosage combination of both estrogen and progestogen in every pill, you have both the lawnmower and the fertilizer, and the lawn never grows. So instead of varying between fertilizing and mowing the lawn, you have both the fertilizer and the lawnmower in every single white pill. So the lawn never grows. In other words, your hormones are the same every day. You do not want this. This package has 3 different colors for the active pills. We have pink, yellow, and blue. This is what we call triphasic. Triphasic means 3 phases. 3 phases means that all the active pills do not contain the very same dosage combination of estrogen and progestogen in every pill. Instead, every color of pill contains a different estrogen plus progestin dosage combination. A triphasic birth control pill will create hormones that are always changing, with variation from day to day and color to color. But that means your hormones will be on a roller coaster. And if your hormones are on a roller coaster, your life will be on a roller coaster. So you do not want any birth control pill that has tri or 777 in its name. Okay, so the first critical characteristic of the right birth control pills for PCOS is that they must be monophasic. What about the second critical characteristic? Continuous. Well, this pertains to how you take your birth control pills. On several occasions in the past, I've taught you about hormone regimens. The hormone regimen refers to whether you take your pills in a manner that produces a period or prevents a period. A cyclic regimen produces a period. A continuous regimen prevents a period. So let's discuss how these 2 regimens affect PCOS. You see this package of monophasic birth control pills? Notice that all the pills are white except for these last few, which are brown. Well, these brown ones are placebos. They're fake. They have no hormones in them at all. So if you take these brown pills, you are using a cyclic regimen, and you will have a period. But it makes no sense to have a period. Why not? Because all these monophasic white pills contain both estrogen and progestin. In other words, they all contain both the fertilizer and the lawnmower. Well, that means the grass never grows, so there's nothing to shed. There is no benefit in having a period to shed the lawn if the lawn hasn't grown in the first place. And the only thing you accomplish by having a period is a period of time without hormones. The whole key to treating PCOS is to keep everything as stable as possible. You do not want roller coastering hormones or lawn thickening and shedding. You do not want periods of time without hormones. You don't need any of this cyclic activity. The alternative to a cyclic regimen is a continuous regimen. So if you throw away all these fake brown pills and you take a real white pill every single day and you start a new package when you get to the brown pills, then you create a continuous regimen. A continuous regimen means that your hormones are the same every single day. You never go without hormones. So instead of alternating between having hormones and having no hormones, you get a nice flat line. And that's the kind of stability that treats PCOS. So the kind of birth control pills that can actually treat PCOS must be both estrogen and progestin, monophasic, and you must take them on a continuous regimen. If you don't want a pill, there is a birth control patch and a birth control vaginal ring that contain both estrogen and progestin. But while there are hundreds and hundreds of pills, there's only one patch and one vaginal ring. So you have many more options with pills. The brand of your product does not matter. Just find what works best for you. And I can help you with this in a consultation. I do this with women all the time. Notice that the official diagnostic criteria include only this first category of failure to ovulate. Both irregular infrequent periods and multiple ovarian cysts are manifestations of failure to ovulate. So the official diagnostic criteria acknowledge only the failure to ovulate category, and the management options for treating PCOS do the same. What this all boils down to is the fact that the only reproductive specific treatment option for PCOS is estrogen plus progestin, monophasic, continuous birth control. And I cannot stress how important it is to start taking birth control early and stay on it throughout your entire reproductive life unless you are actively trying to get pregnant. Women tend to think that hormonal birth control is not good for them, but they are greatly mistaken in that belief. So commonly, uninformed mothers rob their daughters of the opportunity to treat PCOS with birth control because of this mistaken belief. And it's really quite a shame. It's all because they listen to their ignorant girlfriends who claim that birth control is dangerous. All the while, PCOS is wreaking havoc that will endanger the daughter for the rest of her life. The earlier you start taking birth control, the better. So let's add just this to our chart before we move on to the category of ovulation and the other reproductive items on our list. Now you see that I've designated estrogen plus progestin, monophasic, continuous birth control as the only option that can actually treat the failure to ovulate and the underlying PCOS as its cause. And I've designated progestogen only as an option that cannot. But the other category of reproductive abnormalities of PCOS occurs when you do ovulate. So this category pertains to women who have PCOS and still get pregnant. Of course, since ovulation is a real problem, most women with PCOS experience infertility. But infertility is managed as a completely separate problem with no focus on the possibility that PCOS is the cause. The official diagnostic criteria for PCOS do not address infertility at all. And yet, it is one of the most common reasons that women with PCOS seek medical attention. I just want you to understand what a big oversight this is. None of the infertility treatments that serve to achieve pregnancy actually treat PCOS. They merely overcome the infertility caused by PCOS. They are of no benefit in addressing the real cause of the infertility. Likewise, if you do achieve pregnancy with PCOS, you're very likely to have pregnancy complications, including gestational diabetes and gestational hypertension. But once again, these are managed as problems of pregnancy itself rather than as consequences of PCOS. And none of the management options for complications of pregnancy does anything at all to treat the PCOS itself. So there is nothing to add to our chart that pertains to either infertility or pregnancy complications. The PCOS criteria completely ignore both of them. Alrighty, the other entity listed in the reproductive section of our chart is abnormal uterine bleeding. Now this is something that occurs most commonly during perimenopause. Going back to basics, perimenopause itself is defined by a loss of progesterone. But with PCOS, your progesterone has always been low. So estrogen has never been balanced by progesterone. Well, that's particularly what has enabled your endometrial lining to get extra thick and cause the abnormal uterine bleeding. So your first thought may be to just treat this with the progestogen all by itself. But that would be precisely the wrong thing to do if you want to treat the underlying problem of PCOS. The only proper hormonal treatment for it is estrogen plus progestin, monophasic, continuous birth control, pills, patches, or vaginal rings. And what if you have heavy abnormal uterine bleeding that warrants more than just the estrogen plus progestin monophasic continuous birth control, pills, patches, or vaginal rings? Well, the typical treatments for abnormal uterine bleeding include dilatation and curettage, or D&C, endometrial uterine ablation, total hysterectomy, and total hysterectomy bilateral salpingo oophorectomy. D&C merely scrapes out the current thickened endometrial lining, but it does nothing whatsoever for your PCOS. Endometrial uterine ablation merely destroys the endometrial lining such that it can never ever thicken again. It's like turning it into a desert so that the grass cannot grow. Granted, endometrial uterine ablation will help prevent endometrial uterine cancer, but it will not treat the actual PCOS or address any of the other problems associated with it. Total hysterectomy will remove your uterus and your cervix. So you will not be able to have thickening of the endometrial lining ever again, and you will erase your risk of endometrial uterine cancer, but you have still not treated the actual PCOS. The only treatment that does anything permanently beneficial for the abnormal uterine bleeding in PCOS is total hysterectomy with bilateral salpingo oophorectomy. If you remove it all, you take care of the problem once and for all from the reproductive standpoint. This means that removal of your fallopian tubes and ovaries in addition to your uterus and cervix is what's necessary. So let's add all of this to our chart now. Now you see that I have elongated the last two columns in the reproductive row. And next to the abnormal uterine bleeding, I've designated that the only management option that actually treats PCOS as its cause is total hysterectomy bilateral salpingo oophorectomy, while D&C, endometrial uterine ablation, and total hysterectomy without removal of your fallopian tubes and ovaries cannot treat PCOS. Our final organ system abnormality is metabolic, and this is due to abnormal metabolism of insulin by your fat cells. Remember, this is not a problem of insulin production. It's a problem of insulin utilization. With PCOS, your body does not utilize insulin properly. In essence, it is insensitive to insulin. The insulin is there, but your body does not know it's there. From our previous videos in this PCOS unit, you know that this metabolic category is really the most serious. And yet, it is completely omitted from the official diagnostic criteria. Metabolic system abnormalities can manifest as diabetes type 2, abnormal cardiac lipids, cardiovascular disease, increased risk of hypertension, increased risk of heart attack, obesity, and non-alcoholic fatty liver disease. So this is the category that is deadly. But just like the infertility and pregnancy complications that are due to PCOS, everything in the metabolic category is managed as a completely different medical problem, never assessing the possibility of PCOS as its cause. Fortunately, though, treatment of the abnormal metabolism is designated as part of standard treatment for PCOS. So if you do get a diagnosis of PCOS, hopefully your doctor will recommend treatment of the metabolic component. The first metabolic treatment item is an insulin sensitizer. drugs that people take for diabetes type 2. Some of the names of these drugs are metformin, semaglutide, pioglitazone, rosiglitazone, orlistat, and sibutramine. The second metabolic treatment item is a statin drug to lower your risk of heart attack. Statin drugs include all of the following, and I'm not going to say them all. It's just a list of drugs you've probably heard before. And the third metabolic treatment is a means of accomplishing weight loss if you're obese. These include weight loss drugs, gastric bypass surgery, and so this metabolic category of treatments includes treatment of high insulin, high risk of heart attack, and obesity. Ironically, as is typical of the disease care industry, diet and exercise are largely ignored by most doctors, but you need to know that they are very important. You can actually accomplish a lot of your treatment with diet and exercise, but it requires real and persistent commitment. And all of these things serve to treat the underlying cause of PCOS with regard to its metabolic effects. And once again, the early bird gets the norm. The earlier you treat the metabolic abnormalities, the better. So let's add this to our chart. Now you see that I've designated insulin sensitizer, statin, weight loss, diet, and exercise as options that can actually treat the underlying PCOS. And there are no options that cannot treat it except doing nothing. But unfortunately, the vast majority of women do nothing. What you've learned here today is that the actual treatment of PCOS involves treatment of the 3 organ system abnormalities: anti-androgens for high testosterone, estrogen plus progestin, monophasic continuous birth control for failure of ovulation, and an insulin sensitizer, statin drug, weight loss, and exercise for metabolic syndrome. It takes all of these things to adequately treat all aspects of PCOS. If you manage your PCOS with only one of these or only 2 of these, you will not succeed in treating the entirety of the problem. If you try to manage your PCOS without any of these, you will not be managing the actual PCOS at all. You will merely be managing the symptoms and ignoring the cause of the symptoms. The chart is your summary too, and you can find it by clicking the link in the description box for this video or by going to menopausetailor.me. It's always best to go to menopausetailor.me, and that's because the early bird gets the norm. And the earlier you schedule a consultation with me, the earlier you'll have everything tailored specifically to you. It's also best to subscribe to this channel, my newsletter, as early as possible. That way you'll be an official student here at Menopause University. Following me on social media is something you can do early or late. And I'll come back in a week to teach you all about the effect of PCOS on your menopause. Bye, my dears.